So my name is Anthony Manyara. I'm a PhD student at the University of Glasgow, and also I'm affiliated with the Technical University of Kenya. So I'll be presenting on the barriers and facilitators of healthy eating in a low and a middle income community in Nairobi, which is a qualitative study. So my PhD work revolves around type 2 diabetes prevention, which is on the rise in sub-Saharan Africa. And my work is mixed methods. So I've done a case control, I've done scoping review and a qualitative case study, and I'll be presenting the results of this qualitative case study. So diabetes is preventable through target of modifiable risk factors, the main ones being weight, diet, and physical activity. And in Kenya, the consumption of healthy diet is quite low. About 6% achieve the recommended intake of fruits and vegetables according to the STEP survey. So we aimed to investigate the barriers, the facilitators of consuming healthy diets in Nairobi, which is the capital city of Kenya. So we did a qualitative case study in Nairobi. We picked two communities. One is Buruburu, which is a middle income community, which is the photo on the top. And the other one is Mukuru, which is a low income community, which is the photo at the bottom. We recruited about 15 participants, and the first interviews, we did them face-to-face, and then due to COVID restrictions, we did telephone interviews for the rest. The interviews were transcribed, translated, and thematically analyzed. So we mapped our barriers and facilitators on this behavior change wheel, which is a framework that helps to classify sources of behavior. So at the hub, the green circle there on that big circle. So it has the sources of behavior, which is capability, motivation, and opportunity. And then surrounding the sources of behavior is where you can intervene. So you have the red circle, which shows the intervention functions, and the gray circle is the policy functions that you can use to intervene. So we mapped our findings and our themes around the sources of behavior, and then I will be discussing some of the intervention and policy functions that we can use to intervene. So the first finding or first theme was on capability, and capability is mainly on knowledge and skills at the individual level. So most of the participants perceived a healthy diet to be a balanced diet, which may not always be the case. So a diet with carbohydrate, proteins, and vitamins. Few participants, mainly from the middle income community, mentioned healthy diets having low sugar and fat and having adequate fruit and veg, but none of them from both communities knew the recommended servings of fruit and veg. So one of the participants from the low income community says, "No, I don't know," referring to the recommended servings of fruit and vegetables. "I only buy kales for 30 shillings, or even those traditional vegetables for 30 shillings. Just that I don't know what portion I'm supposed to eat." The next source of behavior is motivation, and motivation is concerned with the perceived beliefs, perceived consequences, things to do with habit formation. And so one of the motivators of consuming a healthy diet was the perceived benefits of healthy diet, so such as having good health. So that motivated some people to consume healthy diet. Secondly, the belief about consequences. So knowing the harmful effects of unhealthy diets, and especially seeing the consequences of unhealthy diets in the community. So seeing people struggling with diabetes motivated people to eat healthy diets. Then another motivator, which was a barrier, which is under the motivation source of behavior, was the need to make food more tasty with added sugar, fats, and oils. So leading to people eating unhealthy diets. And people did mention that increased consumption of sugar, for example, led to a decreased sweet sensitivity. So as someone says on this quote, they referring to the people who like sugar, normally say that their mouth has gone bad. That is why they like a lot of sugar. Then the third source of behavior is opportunity, and opportunity is concerned with societal influences, but also the environmental context. And here we had, this was the major barrier and facilitator of consuming healthy diets. So the first of them the societal influences was an influence of upbringing. And so people mentioned that introduction of healthy foods in childhood, transition to adulthood, or the introduction of unhealthy foods in childhood transitioned to adulthood. So a social worker from the middle income community narrates about his experience as a child, and I'll not read the whole quote. So he says what he's doing now, he's taking a lot of starch, a lot of proteins, a lot of carbohydrates, and he thinks that is all because of how I was brought up. We were never brought up being cautious about making sure that anytime you take a meal, it has to be a balanced meal. The other source of behavior was social norms, and this is association of unhealthy diets with a high socioeconomic status and association of traditional diets which may be more healthy with low socioeconomic status. So a consultant from the middle income community says instead of taking maybe arrowroots or sweet potatoes, you see people eating banana cake or eating Weetabix with sugar or granola with flavored yogurt. So such foods are associated with a higher socioeconomic status than traditional foods. So that may have led to people taking more westernized diet or unhealthy diets and taking less of the traditional foods, which more likely have lower levels of added sugar and oils and fats and oils. The other major theme on the opportunity as a source of behavior was affordability. And this was a major difference between the middle income community and the low income community. So woman from the low income community mentions about vegetables being expensive. So she says you'll have to spend about 100 shillings for you to feed on traditional vegetables with 2 children. Now, that was not the case in the middle income community. Affordability of healthy foods was not a concern, as the social worker mentioned, that the perception is always that people to think that you have to have a balanced diet, it is expensive. He says this is not the real, it is not in the real sense, because you can have ugali and you can have omena, and he continues to mention about 100 shillings or 200 shillings, you have a balanced diet. So 100 shillings in the middle income community is not much, but it's a lot in the low income community. Then the other source of behavior is access to unhealthy diets at the opportunity level. And this was mainly in the middle income community. So there is increase in westernized big food industries, such as the Kentucky Fried Chicken, and they are cheap. And so it's affordable. So it's available and it's affordable. So this man from the middle income community mentions about a package going for about £2 or £3, and therefore it's affordable. And so that increases the intake of unhealthy diets. Then the other concern or a source, a barrier in the opportunity level was safety concerns of healthy food, such as vegetables. And this was, for example, the human resource officer says, I have doubts about vegetables because in most cases we are not sure where they come from. Yeah, there's this perception that especially kale and spinach have been planted in most cases we believe they come from sewages. So these may have deterred people from taking healthy foods such as fruits and vegetables. So going back to the behavior change wheel, and from those sources of behavior, we can intervene at various policy and intervention functions. We can educate and communicate about healthy diets using mass media, using health education sessions, so that people can know the composition of healthy diet, that a balanced diet is not always a healthy diet, communicate about the servings of fruit and veg that are needed. We can persuade people about the benefits and the consequences of healthy diets. We can model healthy diets from childhood, since upbringing was a major theme that influenced the diets that were taken in adulthood. And we can have fiscal measures that increase affordability of healthy foods, mainly in the low-income communities. And we can have food safety regulation to make sure that healthy foods that are in the market are safe and therefore does not affect the optimism of people taking or eating those healthy foods. So I would like to thank the study participants, the community mobilizers, my supervisors, and the transcriber who transcribed the interviews. And thank you for listening.